All right, everybody, welcome to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're going to go back to basics, learning the basics from the retinal cases with Dr. Diana Shechtman. She's a graduate of Nova Southeast University College of Optometry and a graduate of the Medical Center residency. She was a full professor for 18 years at Nova Southeast University, where among her many roles, she serves coordinator of diabetes and macular clinic and director of our interdisciplinary education program. She is currently a consultative optometrist at Low Ophthalmology and Associates, as well as retina consultants of Miami. She has numerous national roles. She's a fellow of the American Academy of Optometry. She has been on numerous editorial boards, publications, and lectures across the country as well as international. One of the top retinal educators. So let's have a nice, warm, virtual welcome for Dr. Diana Shechtman. Diana, go right ahead.
Thank you very much. And I do want to thank not only your amazing team, but both of you guys personally. Joe has always been my mentor for many, many years, my professor and my mentor in many different things. And Greg, I've always learned from you and still continue to in many of your lectures. I particularly love your perspectives in autoimmune disease and nutrition. You always have a very nice twist, and the pathophysiology really helps me. So thank you both. And of course, Vanessa, who's one of the most incredible individuals and organizer that I've ever seen. Here is my financial disclosures. They are light, and we're going to continue on forward. All these have been litigated. So we'll start with our first question, because I kind of want to get an understanding of the individuals there. We've already learned that about 50% of you guys have a direct text with your retinal specialist, and that's amazing. But I think for those of you guys who don't, from my perspective, and I know many of them even across nationally, most of people are reachable and they would love to be able to educate you as well. So for many of you guys, you may be able to get a contact number. But I want to get some information from each of you guys in regards to your comfort level. It's going to help me kind of address this lecture. So if we can put this poll, Greg.
It is up and running. You won't be able to see it on your end because it's on this live streaming side, but it's up and running. We have a good response already of people weighing in. How comfortable do you feel with retina diagnosis and management? You can select all. I made it a multiple choice. Very comfortable, but I collaborate and co-manage most cases. Not really comfortable and refer most things. Wish people would stop asking that question.
What about you guys? How do you, I know how Joe feels, so I won't even ask, but Greg, how would you put yourself in any of this?
Yeah, I was, that's why I kind of made it multiple choice. I mean, whenever I was answering this question when putting it in, I feel very comfortable, but, obviously I can't do the injections and, do membrane pills and do argon lasers or treat, with lasers. So, macula on, macula off detachments, but, obviously I have to co-manage and collaborate with those. So, I'm kind of an AB guy, I guess.
And I should have dealt more with the diagnosis rather than the management. Obviously, we're pretty restricted as to how much we can manage. Most of these things require medical or surgical perspectives. But I meant more, I guess, from the capacity of when I'm seeing how comfortable do I feel with the entity at hand. Maybe I need to co-manage with a primary care physician. And you're going to see some of those cases here. There are retina, but don't necessarily need to belong to a retina clinic in and of itself. Can we move forward?
Here's your answers now. 18% very comfortable. We got 46% comfortable, but I collaborate / co-manage most cases. We've got 36% not real comfortable and refer most things out. And we have 0% saying, I wish we'd stop asking that question. So there you go.
All right. So what's the diagnostic modality at hand? I think as retina has evolved over the ages, I worked at the university and did quite a bit of retina there. But over the last decade, I've dedicated my career mostly working with ophthalmology side by side, in particular in the retina practice. So I've learned and used many of these equipments, but the ones that I highlighted or bolded are the ones that most retina specialists have in their practice. A lot of these you will see throughout the presentations today. And I'll emphasize diagnostic modalities in regards to using each one of these. We don't use, and many retinal specialists do not use PHPs or microperimetries. I've seen those at OD practices, and dark adaptation and macular pigment density also are not really used, which allows you as ODs to start becoming more proactive and using these subjective measurements for retinal evaluation. We seem to have so much diagnostic modalities when it comes to retina. We don't have enough, glaucoma, we don't have enough with retina. So let's talk about a mystery case. This is a case that we had just saw, and you can look at the dates here, June. Most of these cases I just saw within the last couple of months. I kind of opened up, looked at the case that I've seen, and popped them in there and figured, okay, let's talk about them. 62-year-old Hispanic male, mild blurred for about 2 weeks. So we have some sort of acute onset. Hypertension, saw his primary care physician within the last 6 months. Visual acuity is just mildly affected, but it is affected, and the patient has noticed. So when we are looking at this, and I've worked with many interns, residents, I work with ophthalmology residents, people seem to want to usually come up with a diagnosis immediately, which is great, but it might be a better way. You step back and you make a description of what you're looking at, and it helps you better to tune into the differentials at hand, which helps better collaborate with your retinal specialist, even to setting urgencies and emergencies. Right here, we're looking at exudative matter parafoveally on both sides. Both of these exudates show right here as hyperreflected areas. Of note, exudates are usually in the inner retina. So almost always you'll see it right above the OPL, the outer plexiform. They're not usually under it, and they're not as superficial. In addition, this defect down here is not a real defect, but it's light being absorbed by the heavy reflectivity of the exudate itself. A cystic change in the center may not be so obvious. And another thing to describe, the patient has hypertension here. So could this be related or not? This was not a polling question, but this is just a thought process of what we're looking at. Diabetes or diabetic macular edema is definitely in the differential. Patient does not have diabetes of known. They have seen a primary care physician recently, but maybe it's not diagnosed. So maybe it was a pre-diabetic type, and the patient is not telling you. Idiopathic macular telangiectasia. I saw a lecture of yours here, maybe a couple of years back. Jay Haney did a fantastic job with regards to describing it. And that was one of the major differentials I was kind of considering at the initial perspective before getting the FA. Hypertensive red, not likely for two various reasons. One, hypertensive red tends to be a disease of the vascular, the top layers. So most of the time, it's not a wet disease like diabetes. It's not a capillary disease. You're looking at flame shapes. You're looking at Cowell spots, AV crossing changes, nicking. None of these are standing here. The diabetic macular edema, although can look exactly like this, you had 0 diabetes in the contralateral eye, and patient has no history of diabetes, and there's no microaneurysms whatsoever. And how do you differentiate between the idiopathic macular telangiectasia and the BRVO is the FA right here. The FA is really showing you an area of mild diffused edema, which we obviously saw as that central cystic change on the OCT, but there's none of the spider web like it. I'm going to show you that on the next one that you see from the capillary incompetence that are associated with idiopathic MAC-TEL. Most of idiopathic MAC-TEL begins on the temporal side, primarily due to the fact that the patient has less perfusion in that area. So this, although not obvious, you can see the vasculature abnormality here. These are small collaterals on this area, almost telangiectatic vessels bridging through, and this is a small BRVO. Any comments, Greg? Any thought process on this? What do you think my surgeon may potentially do in this case? Or knowing from your retinal specialist who you worked with in the past?
Yeah, I don't see an OCT. I'd probably do an OCT, but I would probably just observe this right now and monitor this patient at this point.
OCT on the previous picture. Let me show you right here. This was the OCT right here.
Okay, so you got done that on that. Looks like was that the right eye there? That big old fluid space. It's 2025. Here's probably what I would do for this patient. I would say, look, you see this swelling here. This is not good. Your diabetes is a capillary disease. I would personally follow it. I would say to this person, can you do something really good over these next 3 to 6 months? Not that it's gonna be that,
Dramatic
you know,
or
not that it's gonna be a direct relationship, but I would follow that and see him back in 3 to 6 months to see how bad it gets at 2025.
And that's not a bad thought, 100%. Now, in doubt, oftentimes retinal specialists will offer on a mild decrease in visual acuity to potentially do an IVA, but it may be very well followed on this patient at hand. So you're 100% right. And especially if this were, and it looks like diabetes, and the reason why we kind of went against diabetes was the fact that patient had no history of diabetes here. And in looking at the contralateral eye, there wasn't even a single microaneurysm. And right over here, you can look at this very, very small, and you would see it better on different FA frames, of the small dilation of the one single vascular that actually exploded into, it's almost like a twig BRVO. But either way, presenting almost identical to the DME, as you mentioned, and the option of IVA is given, but not substantially told you have to do an intravitreal injection. In this case, a patient was offered and the patient decided to use it. Most patients are not really fond of having an injection, but they were complaining of blur and opted to do it. And a lot of other patients may opt against it, and you're 100% right. It could actually be followed. As an example for idiopathic macular telangiectasia, as we mentioned, that look very similar to this. Look at this. You got a cystic change here. You got some exudations, almost identical to the clinical picture presented before. The major difference is the overall presentation, particularly on the FA. And I think OCTA is exquisite for this. We obviously have FA, so we don't have an OCTA in our office, but I am getting it at Lowe's office, so I'll have more of those images. But you see this spider-like web appearance? That's classic for idiopathic MAC-TEL. What it is telangiectatic vessels, they're literally incompetent and they begin to dilate and leak. And that's the example as presented here. A little bit different than the presentation on the FA in the other case. Either which way, an IVA, the injections for Vitreomacular, Avastin, or injections of Lucentis, etc., can be used in these cases at hand. Now, just a brand new thing for you guys to be aware, much like, and I know you guys have done a clinical presentation for GA, there are new drugs coming about. Idiopathic macular telangiectasia has a secondary form called a type 2, and there is and this is as early as June this year, FDA grant priority review to get a new drug in the market, which may be here by December, as the company stated, for ciliary neurotrophic factors to be able to treat this disease. So we have to be, as ODs, more aware that the disease is present, primarily because now there's a drug and we may be able to send the patients to get treated when before we didn't have much treatment, or we waited for abnormalities like a choroidal neovascular membrane to present. Now, I know many of you guys, and I should have put this on one of the slides, probably look at pictures oftentimes, maybe even before you look at the patient, your techs are doing picture and you're getting a feel for what's about to come. When I come into the office, I have my text, I have my OCT, my pictures, any other testing of fundus autofluorescence and ultrasound, and it seems like we have all these before we meet the patient. But here is a particular pictures on when things go wrong. Young lady comes in, told she's been told that she had a scar, may have been a possible toxo scar. We can see a very large vitreous detachment, and toxo loves the posterior pole. Toxo loves to disrupt the vitreous. Oftentimes there's large floaters. And of course, during an active stage, you'll have vitritis in a symptomatic patient. When the OD send me a photo to tell me about the case and saying, listen, I want to send it to the office, they told me they were worried that the patient had a retinitis. So looking at here, I obviously think certainly, but I kind of was a little perplexed. Why? Because the patient, as told by the OD, was completely asymptomatic. 20/20 visual acuity, pressure was normal. There was no AC reaction. I said, do me a favor, before you send it over, just finish out the dilated exam. Let me know, is there a clear view in? Look right behind the lens. Is there a vitritis? Look at the so-called retinitis. Tell me what you're seeing in there. So the OD did as such and comes back to tell me that pressure's still low, no pain, no photophobia, decrease. There's no decreased VA. They're 20/20, I think. There's absolutely no floaters reported by the patient except for that large one that they've seen for years. And when they looked inside, there's no retinitis, just a scar and that vitreous debris. Things didn't make sense. I'm like, it's obvious. We're looking at this picture right here. There's this retinitis here. What is anyone thinking at this point? So I turned back and I said to them, do me a favor, take your camera, clean that lens, and just retake the picture again for me. See what happens. Lens is clean, view is clearer, retinitis disappears. And we're left with there was vitreous debris there. The patients had it for a long time. They did have an old, possibly toxo scar. It wasn't confirmed as toxo through IgG and IgM, but that retinitis disappeared. And we have a lot of times these like fingerprint maculopathies. I've gotten all kinds of pictures that the patient may have had a retinal detachment during the time that the mask got into the view of the photo. So you always have to compare the photos with what we're looking at the back of the eye. And the photo should never substitute a dilated fundus exam. Agree, Joe? Any thoughts? I'm sure you've seen a lot of cases.
I agree with what you said. And as you were saying, it just came to mind. I was asked to try to defend a colleague in a malpractice case where a wide field image was taken and a choroidal mass was seen. And the patient was referred out to ocular oncology at a major metropolitan hospital. Now, this patient had been complaining of flashes and floaters and had 20/30 vision, but 10 days later, when they got to the ocular oncologist, they had a complete funnel retinal detachment. And it was never a choroidal mass. It was always a retinal detachment. When I saw the when I saw the Optos image, I mean, the first thing I said that was a retinal detachment. And I had to tell the attorney that that your client is up that well-known fecal-laden estuary without a means of locomotion, and had fornicated with a canine. So,
boy,
I really couldn't go much farther on that one. But the key was an image was taken, but an exam was not done.
That's a great example. Thank you for bringing that up. Greg, do you have a comment?
Yeah, can you go back to your picture of the toxo scar? When I worked with a retinologist, I don't know, for about 8 years, and he used to always give me kind of pearls. So that lesion that's at the top up there, I'm going to just say that even though it's not confirmed, I would say pretty strongly that it is. And so what he taught me, when you're looking at a toxo scar, at least toxoplasmosis, that it always burns to the sclera. We can see that. And it usually has a satellite lesion, which is that little satellite lesion right, just go over a little bit, just so it burnt to the sclera. And then the satellite lesion is just that little circle beside the big circle. So that would be this right there is your satellite lesion. So he says it usually does three things: is that it's very pigmented on the borders, burns to the sclera, has a satellite lesion. And every time I look at a toxo scar, it is pretty much dead on, and that has helped me out in telling other types of like histotypes of pathology. So I would bet if you did run the serology on this, I would bet that it would come back to that was toxo.
That's an excellent clinical pearl, Greg. Thank you so much for sharing that. That's a really good clinical pearl. Lara pants on fire. Let's see where this one takes us to. 33-year-old white male comes in with, he's a keratocone. He's actually sent, so a lot of times I may see also ophthalmology practice referrals, or may see our ODs and colleagues. Patients complaining of floaters for about a month, had a previous flash, but that disappeared. So obviously we're thinking, okay, the patient has a PVD, no big deal. Take an Optos image. This Optos image looks completely unremarkable. Correct, Joe? I mean, if you had to defend this case, and this is the only thing you had right now, granted, obviously we have to do an exam, and I did, but by the photo image here, this is not like the previous case you described, where you stated that there was a retinal detachment there, but the patient misdiagnosed it as a mass. They saw something. I see nothing here. It looks absolutely normal. But if one doesn't dilate the patient, you would not only miss a pretty small retinal tear. And what's interesting, and I've seen this over and over again, I've seen huge, very large retinal tears that did not lead to an RD. And I've seen little tiny ones, and you're going to see later some what we call micro tears that lead to a retinal detachment. But this is a view of the same patient, but it's taken a little bit off. Whenever I have questions on my patients or I want to take better photos, I ask my techs to take wide fields, but off center. So I'll have them look all the way up, all the way down, all the way in temporal and nasal, trying to enhance my view even better, although I have an optos. So this is a wider field towards that field of view. There is a micro, it's a relatively small tear and a large retinal detachment. Patient being young, my retinal specialist decided to actually not do a vitrectomy, but do just a buccal. A vitrectomy or gas will induce and cataract for sure, and the patient was 33. And what we're looking at here, and I'm sure many of you guys have seen buckles before, but when you buckle the retina in and you indent it with this little silicone, this big area on the side for those younger ODs who may not have seen buckles and probably won't be seeing too many buckles nowadays, that retina looks detached. It looks elevated. Sometimes there's a lot of scarring and cryo, but a good one just has a nice little indentation. You're trying to bring the sclera back to the retina and kind of fill in that space and remove the liquid. And instead of doing any laser on the actual tear, he put an extra silicone. That's why there is an area that's indented outwards towards you for extra support where the tear is. And the patient has done very well thus far. So this is one of the few retinal detachment surgeries that we do. Most of the time, a vitrectomy is the one that you would see. And if you wonder if a patient ever had a vitrectomy, just look at the vitreous. If it's an older patient, there should be debris on the vitreous. If they've had a vitrectomy, there's going to be water there. The vitreous will refill, but there won't be that fibro-like area that you will see as a patient. You won't see aneurysms. And that's how you know they've had a vitrectomy before. A newer study, and it's not so new anymore, but relatively new, it's called the PIVOT study. And you will see that some of your retinal specialists will do a mnemonic retinopexy, which is nothing more than a gas bubble in the office to repair a retinal detachment that's superior with a single tear. It is basically a waiting to go to, say you have it at 5 o'clock on a Friday, a waiting for them to have surgery over the weekend, because they're not going to do surgery on the weekend. I'll tell you that unless they own the surgical center. Or you're hoping it would stay well and seal, but some of my surgeons don't really like it. They've seen that many of these will detach again, but the PIVOT study proved it to be relatively effective. And laser may be done in a very small localized inferior retinal detachment. I've seen that before just because they're trying to prevent them from going to surgery. Any thought, guys, regarding any of your perspective about surgical repairs or any of that, or even the case itself?
No, I have no comments. You did cover that very well.
All right, so
No,
this
I agree, and I think it behooves people to understand that just because a retina may be detached does not mean that the surgeon's going to go in at midnight and patch it up. You know, in most cases that I have, either our in-house or affiliate retinal people will they'll inject the gas to buy them some time. Patient can digest their food and they get onto the surgical schedule.
And actually the digesting food is important, because in order to go into a surgery, not only do you have to have the surgical center open, but the anesthesiologist on hand wants to know when the patient ate their last meal. Sometimes there needs to be clearance. The patient has to go to cardio. So very good clinical pearl, Joe. That's 100% right. So this is my 5 o'clock shadow case. So calls in, and it's so true. Until I started working at a retina clinic, you're going to get retinal detachments at 5 o'clock. I swear people wait 3 to 4 days to come in, but they don't want to ruin their weekend over it, even though they've had a field defect, even though they've had decreased vision. Patient had a shadow in the vision for a few days, but now it's 5 o'clock and the patient decides to go in, whether it be our retina practice or an OD, and I get a call from this. So let's say it's the OD and they're calling me at the office. It's 4:55. What is my one single question I'm going to ask that OD with regards to this retinal detachment? What's my retinal surgeon want to know right now?
Macula on, macula off.
100%. But if you work for a good retinal surgeon, usually they ask about insurance first. Just kidding. No, the macula on or off is 100% correct. So obviously, what are we going to say on this one? Off, correct? See a nice little retinal tear off to the side. Look at the macula. Macular is actually on. That is a draping retinal detachment over the area in question. Now, technically, I wouldn't say the macula is on, and here's why. Because this is a cube within the macula, and the superior aspect of the actual macula is impacted. But believe it or not, the fovea technically is on. So it's an interesting case where we would look at this and no one would even question they have decreased visual acuity, but the fovea is technically on this patient. And the reason for the importance of it is this becomes that much more of an emergency at hand. And it becomes a bit more difficult to work with these very bullous ones. They usually need a retinotomy, which is that they'll actually put a hole inside this to release some of the fluid and then re-laser it. And this patient will probably end up with a more longer lasting gas, I would say, as C3F6 rather than the SF6. So it lasts longer to kind of impact and, of course, a vitrectomy. But all these are real cases. So what I'm showing you are cases that have actually come to the office, and most of the cases I've seen. I will share this with the audience, and here's why. Because I find it oftentimes that we've gotten cases where people don't think it's an emergency or an urgency, when in fact it really is. But oftentimes we also get cases where everybody freaks out, particularly when there's decreased visual acuity, mass amount of hemorrhages. We get a little more nervous, but sometimes some subtle changes could actually be a secondary problem that needs to be seen in the office. So I'm happy to share this slide with you. This is a slide that I've created with my retinal specialist. So we have it kind of in office. What's an urgency? What's an emergency? And on the side of the, must be seen first day or within 48 hours, proliferative diabetic ret with a high pressure. And most of us, I don't think, feel as comfortable with gonioscopy as we should, is an emergency, because that may potentially be neovascular glaucoma. We're not seeing it. And sometimes the neo may be very subtle in the iris. It doesn't have to be as obvious before it sneaks into the angle. We've seen some of those cases at hand. CRAO, and I know, Joe, you've pounded this in a lot of people, and it's a great work that you've done regarding the urgency of an acute CRAO being sent to the hospitals, particularly the EDs that have a stroke center. So those are important to go directly there rather than our particular practice. Macular hole and central serous, most of us would say, look, that's not really an emergency. But the problem is the central serous patient is often very nervous, and they're going to make it an emergency. They're the ones who are going to call us earlier than the OD calls us. Macular hole's not an emergency, but when you go to a stage 2 and 3 and they need surgery, if we wait too long, and especially down here in South Florida with authorizations for surgical and then clearances, we're waiting longer and longer periods of time. So we'd like to see a little bit shorter, because we know it's going to be a lengthier time before they go into surgery at hand. Any questions? You guys agree or disagree? Anything you would move from one side or the next?
No, the only
No,
thing
I
I would
don't
say,
think
stroke ready
so.
hospital. I would say with the
Mhm.
CRAO, you go to a stroke ready hospital. You're not going to call your retinologist. That's only not anything I would change. It's definitely an emergency visit just to the hospital. I don't know, Joe, while you're commenting, Diana, while he's commenting, can you go back to a photo that just has like just a retina photos, and then Joe, go ahead and make your comment.
Which photo?
The only thing about the central serous is not everybody is as comfortable ruling out the cause of the swelling as being a choroidal neovascular membrane. So that's something just to consider. And that may make it a little bit more urgent if there is suspicion of that.
Very, very good. And that's why we also kind of put it in the same place as I would put the choroidal neovascular membrane. It should be definitely within a week. And that's a great point. As a matter of fact, today at Lowe's office, we saw a patient who was 68. I don't want to call him elderly, because we all know that age is relative based on the age that we are at right now. I used to think 50 and 60 was old. Now I'm thinking 80 and 90. But nonetheless, that's a great clinical point, because that patient had what seemed to be a central serous choroidopathy or retinopathy, but given the patient's age and some RPE changes, we have to rule out, and we need an FA to rule out a choroidal neovascular membrane. Great point. Which picture did you want me to go to, Greg? I wasn't.
You know what? When you come to a retina photo, I'll make a comment to it just
Sure.
regarding the macula on, macula off. So
Sure, we'll do that. Well, this particular patient, as kind of the case goes through, I wanted to give you a little bit of heads up, because it's going to lead to things if we get to them. But I will finish the lecture on time, I promise. I know there's a difference between a captivated audience and a captive audience. But this is a 1 month out patient. who I told you got a bit of a thicker fluid on there. So it lasted a little bit longer. These patients cannot fly. That's an important one, especially down here in South Florida, that we let our patients know until the bubble is gone. And the patient will notice that the bubble is gone before you are. Even the smallest bubble, you might have like a 10% bubble in there. The patient knows it's there. They can see it. But this is about a 40%. Patient is doing very well. Retina's attached. We obviously looking at the area where the bubbles is not. I'm not worried about where the bubble is, if there was a small detachment there. And that white area in the corner is a cryo that was done during surgery, obviously sealing the hole. But the patient was asked to come back a month later again, so it should be almost towards the end. And at this point, he comes back 1 week earlier because he got a little nervous. He stated, bubble has gotten smaller, but I'm starting to see extra new bubbles. So he was worried, has one area detached? Has something changed? And obviously, after suffering through that, one would get nervous. But over here, we clearly can see that the 3 little bubbles he was seeing were just kind of reconfiguration of the smaller bubble, just getting smaller and smaller. So we explained to patient, you're doing great. We'll see you next time. And the next time we saw him, or I had seen him a while later, was 6 months later. But it was due to a complaint of a floater on the contralateral eye. Obviously, you can see the small PVD inferior to the nerve. There is a small operculum, as we can see here, and there's a retinal hole. So what is my surgeon going to do now? One would say, well, a small operculum is evolved. There's no more attachment there. But this is technically symptomatic because it occurred during an acute PVD stage. And given the fact that the patient has had a retinal detachment in the contralateral eye, this is a patient that at least is offered treatment at hand, only because of the history. And this is where you can't just say, I'm going to follow every operculum, I'm going to send out every flap tear, I'm going to follow every atrophic hole. History in the clinical picture makes a really big difference whether some may get treated or not. And I'm hoping towards the end of the lecture, we're going to get into that. Greg, did you want to mention anything about the macula on and off? Does this picture help you, or do you want to wait?
Yeah, this is a fantastic picture. What I want to point out, and maybe you can use the pointer, what I want to point out to the audience, it's not fovea on, fovea off. It's macula on, macula off. And what we want to remember is that the macula is, as you're circling it there, it's 5.5 millimeters by 5.5 millimeters. So you could say 2 disc diameters on one side and 2 disc by diameters up and down. And the reason why I want to point that out is because that macula is big and it could be on, but that adjacent fluid could be a millimeter away. And whenever I chat with the retinologist and I say, yeah, the macula is on, but we got about a millimeter, so then we'll tell the patient not to eat after midnight, no reading, right? Go home and watch TV. And because we don't want that macula to come off, we don't want that fovea to come off, because then it's just a longer visual recovery. So I would just like to point out to the audience, remember, the macula, and I do polling questions whenever we do these, and a lot of people think the fovea is the macula, but the macula is a lot bigger than we think.
Excellent, excellent point. And if you kind of think about it, for those of you guys have an OCT, that cube is a macular cube. So it doesn't go through one little line of the fovea. It goes through a cube with several different lines. Great point, Greg. That's a really good point.
And Diana, before you move on,
Sure.
we get too far away. A question came in, which I think is a very good question. And it goes to the urgency of referrals. We're being asked, vitreous hemorrhage, no views of the retina. Is that a same-day referral?
Great question. I think it's going to vary pending again on clinical picture on this one. Here's why. I think if a vitreous hemorrhage, no view to the back, probably should get a 48 hours because you're not sure what you're looking at the back. What ends up happening is many of these are secondary to diabetes, proliferative diabetic ret, especially if the other eye just looks like a hot mess. You pretty much know that this is a patient with proliferative disease. But it still doesn't help you to rule out a tractional RD that may be there and it may be very close to the macula. In addition, and I just had one, and I should have put a great picture on it a couple of days back, had an Asian female, 35 years old, who came in with symptoms of acute PVD a couple of days before, lost vision completely, shower floaters, had a vitreous hemorrhage in the back, and there's no signs of diabetes. That's really proven a retinal tear and or detachment until proven otherwise. So given the fact you're not looking at the back and you don't know what you're dealing with, unless you're 100% sure you're dealing with a PDR type of patient, and whether there's traction or not, we can't tell, I think it does become an emergency, or an urgency at the very least within 48 hours. So great question. Any others, or we're good?
We're good.
You're
Okay.
caught up?
We're believed to have it. Let me thank you for bringing that question up because I'm going to definitely add that one to my urgencies and emergency list. Patient had come in, believed to have an RD. You look at the back of the eye and the patient looks fantastic, yet the visual acuity is 2400, vision loss for a couple of days, cataract surgery 3 months ago. Looks great, was believed to have an RD by an OD, sends it over and goes, look, I can't really see the RD, but obviously there's something going on. I'm a little bit nervous. I think Greg already has the answer to this one. So here's what's going on. Patient, right before I showed you that photo, had asked and this is a couple of years back, I had an office where I had interns. I had asked my intern, do me a favor, go take a photo of the back of the eye. And that's the photo they had shown me. Let's get some imaging and see what's going on. But as the patient is right behind the optos, the patient would state, wait a second, hold on, I can see. No, wait, I can't see anymore. No, wait, I can see. And literally was back and forth on having his vision coming in and out of the view, given the fact the IOL was dislocated and kind of literally floating, it was right behind, and the anterior vitreous floating into his view. He could almost see perfect vision and it would float right outside the view. So we were going to talk to a retinal specialist. It wasn't necessarily an emergency. Patient needed a lensectomy, obviously a new lens. This now becomes a retinal specialist surgery. The cataract surgeon doesn't want to touch this. It's now gotten to the vitreous. It's going to need a vitrectomy. Cataract surgeons may do a little bit of an anterior vitrectomy, but they don't get too much into the vitreous. And given the fact there's no place to put the lens, the patient, they don't want to put an anterior chamber IOL. So the patient may need a sutured lens that's sutured to the sclera. You probably will see those in the future, and a sulcus IOL. But regardless, patient didn't want to go. He was going to Disney. So what did we do? We gave him we found out his refracted error. We gave him a contact lens, let him go up and down his little rides, and came back and had a full surgery and did very, very well. Joe, this is right up your alley on this particular case because this was a reading center, like you mentioned before. The patient was diagnosed with macular degeneration, both RPE changes in the back of the eye, by a reading photography center and sent to ophthalmology. Note that this eye is completely unilateral. There's zero drusen in the other eye. Patient is of age, I don't remember, 60s or 70s, to have AMD, and told go see the ophthalmologist when you can. Now we got CR office, and these were the findings as such. As you can see by the picture on the bottom, it really wasn't as white, it wasn't drusen on the back of the eye. Given different imaging modalities, you are going to get what we call false colors, and you got to get used to what the colors look like depending on the photographies you use. But this wasn't drusen, it was actually lipofuscin. The area in question that we're looking at is about 3.5 disc diameters in size, which is equivalent to almost 6 millimeters in size. Fundus autofluorescence reveals increased autofluorescence commonly associated with lipofuscin. As you can tell back here, there is definitely an elevation to the area in question, about 2 millimeters. And you can certainly see the elevation on the OCT, the small amount of fluid. And you see these little deposits. These are likely part of the lipofuscin. It's what is now known as a shaggy PIL, photoreceptor integrity line. And all these are clinical signs of a small melanoma. So the patient did not have AMD, but they actually had a small melanoma. So kind of similar to the case that you were talking about before. So talking about OMAs, this is an example of a patient who may change over time, but is subtle. And that's why ultrasounds are really important when it comes to diagnostic modalities, even of small tumors. When you're looking at a large tumor, it's obvious. Joe, do you know what size the one that you saw was? The one that was misdiagnosed with as an RD? Do you recall the size of that one?
I saw records in there. There was a wide field imaging. I've got to say it was probably 6 or 7 disc diameters.
Okay, so that's a pretty large size. We don't usually are going to call that a large nevus, but we have to remember.
But that was a retinal detachment. That wasn't a tumor.
No, I understand, but
Yeah.
but even itself, I'm saying the size of it. That's why they didn't even call it a nevus. They were looking at it as a tumor. So it's obvious when something is large. It's obvious. It's not as subtle. Here, the example that I'm getting at is that you're going to have something small that's going to grow over time itself, or it's going to grow from the original one. Either they convert, and nevus converts, one in about 9,000, according to the Combs study, will convert. But sometimes what you're looking at has always been a small melanoma that grew over time. So those are the importance, because you look at these pictures over a year, most of us, I would say, there's absolutely no change. And it looks the same, and it looks relatively benign. But if we don't do an ultrasound, we miss it, because something can grow in diameter, and I've also seen the ones grow up and down. So in this case, there was substantial increase in height. Anything over 0.5, according to Tim Murray. I was lucky to do a 6-month sabbatical with Murray several years back, but anything, according to him, as far as change over time with 0.5 millimeters or higher, when talking about thickness, signifies growth and signifies likely a melanoma until proven otherwise, because a nevus should not be thickened to begin with, certainly should not grow. And Tim Murray was the ocular oncologist, as I'm sure Joe knows very well, at Bascom Palmer, but now has his own practice. And I believe that Gold has done a lecture here before. Incredibly knowledgeable, wonderful colleague. So next poll question, Greg.
All right, let's get that up and running here. Where is the, no, that's not, hold on.
Or did I not?
All right, got it.
While the
Polling question is open. Where is the primary site for uveal melanoma to metastasize? We have liver, lung, bone, skin.
So any questions from you guys, or any comments regarding nevus, melanomas, any clinical pearls you want to share with the audience?
Well, we have a question here. I'm going to have Christopher put some more information in here. He has a patient with suspected CME post-op cataract right eye, best corrected visual acuity 20/30, 20/40. After FA was determined that there's a macular schisis. And it says, is that likely to get worse or stable? So my question is, it's hard for me to answer. Maybe Diane and Joe maybe know the answer, but I would say, what is the macular schisis from? Is it from like a vitreomacular traction? Macular schisis, right? It's retina schisis separating out in the periphery, macular schisis, kind of that loose association between the inner and outer retina. It's separated. What's causing it? If it's not fluid, it's got to be something like an epiretinal membrane. And then if you're asking if it's going to get worse or stable, well, if it's an epiretinal membrane, the answer is yes. It could get worse or it could stay the same, depending on how it matures. But I'm not sure if you have any other information, Christopher, on that one.
The one thing I can tell you, Christopher, the reason why they maybe made a clinical diagnosis, that I'm sure your case looked very much likely in the OCT, like fluid, because it looks like cystic changes in between. But what you're looking at is the Mueller cells, just like Greg pointed out, the inner retina separating from the outer, the Mueller cells stretch, and the space between the Mueller cells become what look like cystic changes. The FA proves it out because there's actually no leakage. There's no actual physical fluid. Hence, they know it's a macular schisis. There are two forms. There are the X-linked retinal schisis, which is in congenital form, usually in children, bilateral as a part of inherited retinal diseases. But the one that you may or may not have had, and it's the whole world right now, that we call the tractional myopic maculopathies. So what it's more likely associated with is patients have a staphyloma, which pulls the retina downward. But the vitreous itself, and there could be an epiretinal membrane, as Greg pointed out, does not go downward as the staphyloma grows. Hence, there is a clinical separation. Some of these may stay stable and some of them may worsen. They're a little bit difficult to treat just due to the fact of where it is. And if I believe towards the end here, I do have a picture of one to show you the whole entire world of tractional myopic maculopathies we call, but that's a great example of it. And I'm glad that you were able to tell the difference, because if you started the steroids and the NSAID for that, it would go nowhere. It would stay the same.
All right. So your polling question here, great explanation. Thanks for adding on to that. Where is the primary site for uveal melanoma metastasis? So people are going to have to pay attention, because Diana, we have 49% saying lung. We have 5% saying bone. We have 19% saying skin, and 27% saying liver.
So The top answer is actually the liver. And,
It
and the
is the liver.
problem with this, if you think about it and it kind of makes sense, you look at the choroid, you're talking about fenestrated vasculature. And as a fenestrated vasculature, when it leaves the body in and of itself and it goes through, all our blood usually goes spleen itself and it goes through the liver filtrations. So that's why the liver ends up getting all this filtration from the choroid. The problem is that by the time you are diagnosed with liver cancer, it is too late. There really is no good treatments nowadays. They actually have clinical trials that they put these patients on. So we want to, the ocular morbidity isn't even as bad as what we could have in regards to the patient's mortality when it comes to choroidal melanomas. So what we really have an impact on is the metastatic changes. The reason kind of I wanted to bring that up, and I wasn't going to discuss it tremendously, but I did want to bring this up for two reasons. One, this case on the side was actually a very young lady. She was probably in her 30s, just recently had this case, maybe a few months ago, 3 or 4 months ago. Patient was referred by the OD with a great job who felt they had found an iris, either nevus or melanoma. They were a bit concerned because they had this small change right here off to the side. Now, if we notice this little furrow right here, this whole area was elevated. The patient did not turn out to be like this overnight. This grew over time. But when you fully dilate the eye, you're actually seeing the ciliary body melanoma coming into play. And this view here was the ciliary body melanoma. It wasn't like an artifact or a shadow in the back of the eye. Ciliary body melanomas probably have a higher percentage of metastatic, even over choroid. Thankfully, these are rare, but they're not rare unless if they're in your chair. And I think Luca Tanya used to say that. The other reasoning for prognostic indicators of metastatic, like which will actually metastasize, may include advanced age, thickness, as well as tumor extension into the extraocular. But does anyone know the number one way to truly tell if something is going to metastasize or not, or the chances of metastatic? It's not if there's fluid in the back of the eye or lipofuscin or the thickness, but it really has come down to genomics. It's really where it goes to. So when we talk about a lesion in the back, a small nevus, for example, I always like to write down, and you can use whichever mnemonic you want. There is 2-point small ocular melanoma. There is moles. There is Dr. Gas. But what I'm looking for is there fluid? And that I can identify that by running an OCT if I can over the nevus. Is there any lipofuscin? Fundus autofluorescence is exquisite to show lipofuscin. Do I see thickness? It doesn't even have to be 2 millimeters. If I see any thickness, it's thickness. Size, anything bigger than 3 to 5 disc diameters. And of course, like we showed you some of the examples, document change over time. That to me means I'm now looking at a small melanoma. So those are the signs I look between a nevus and melanoma. If I'm worried now that what I'm looking at is a melanoma and there's a chance of metastatic, particularly to the liver, this is where genomics comes in. So someone like Tim Murray would go in and biopsy the actual tumor, not biopsy to determine if it's a nevus or melanoma, but biopsy to determine if the tumor they have has a very high propensity towards metastatic cancer or very low propensity. And this becomes incredibly important in changing someone's mortality. So it's not just the ocular morbidity, but we're looking at people's lives, particularly because of the chances of going to metastasize towards the liver. And this is personal for me because my uncle was misdiagnosed with having a very large nevus that kept on growing, and it ended up being a melanoma. And I didn't get to see him until it was relatively a large size, which I already feared for the melanoma. Tim Murray had been the one who treated him, and he ended up enucleating the eye because after treatment 7 years later, it grew minimally. But if there's any growth after radiation, you're worried. So, and even though he didn't have a 2, he had a 1B, which is a smaller chance of metastatic, but they're still there. Any questions?
How about, can you, since we understand it, maybe just kind of, when you're talking genomics, you know, they're not literally taking the tumor out. They're using like a needle biopsy going in, kind of taking it out and doing genetics on it. And it goes back to that slide, you know, because I'm going to let you explain it a little bit more, but that goes back to, you know, I had a patient come in that had an ocular melanoma, never went and had it treated, and came back 4 years later. And I'm like, oh my gosh, it's in their liver. And it never went to their liver. So you might want to talk, then they went and did a needle biopsy on it and found out that it was one of those that was, I guess, safe. So like that's what so right there is, if you want to go over that a little bit, talk about that little needle biopsy, that's what
Yeah,
you're talking
I mean,
about
it's
with the
exactly
genomics.
what you stated, and that's exactly what they do. When they go in, they have to do a small core vitrectomy, but they go in with a very small needle, and it's got to have some thickness, because if it's flat, you can't take it away. So that's got to have some thickness to take a little individual piece, much like you would take on your skin, and they send it out, and it comes back with this whole entire formation. Are we looking at a class 1A? Are we looking at a class 1B or class 2? They'll talk about the spindles and the different genomics on it, but it will actually break down the chances of being metastatic free as opposed to chances of having metastatic cancer, metastatic free at 3 or 5 years or so on. But it's exactly like you mentioned it on there. This is often done. It's not done by a retinal specialist per se, but it's an ocular oncologist. We just happen to be lucky to have Bascom Palmer and Tim Murray in our own backyard. Do you guys have somebody near you who does it?
Well, I'm lucky enough to be at least 3 hours and 45 minutes from the Shields and their disciples that are out there. But there's also a couple of the disciples that are in Pittsburgh. So yes, I mean, kind of that whole Shields kind of group that I have the ability in Pennsylvania to reach out to them.
Best of the best, for sure. I mean, I thought I had Bascom, but Bascom has had a rotation for the last couple of years. We had Harbor, who actually wrote the clinical trials of the genomics. We had Tim, who was the ocular oncologist there for many years. And then I think we had Harbor's wife, and now we have a new doctor, Basil. Great guy, really good. And what's amazing about these people, they're literally you can pick up a phone and talk to them. That psoas body melanoma was actually seen by Basil, and he's the one who kind of explained to me different perspectives about it, but he's a great educator, and I love that. Any other questions before we move on?
Nope.
So we're looking
Nope, you're good.
We're looking at 2 dark lesions here. And I put them fairly alike for the same reason. This is not to say a difference is now between a nevus and melanoma. This new dark lesion is going to be a bit different, but they can look very similar. Major 3 differences between them are as follow. The one on the left side, which is a CHRPE, congenital hypertrophy of the RPE, is flat. So when looking in the back of the eye, there's absolutely no elevation to this. As a matter of fact, and I do want to say this because I did see one single case, we always think of a CHRPE being completely benign when we look at a single CHRPE. We're going to talk about multiple. But if a CHRPE has a small elevation within the area, almost as if you have excess pigment in a corner, there may be a very small chance that it can transform to what we call an RPE adenocarcinoma. So even though CHRPEs for the most part are like 99% benign, there is a very small chance that if you ever see a CHRPE with excess pigment on one corner that's actually elevated, that should get a second opinion. This has a well-delineated border, or what we call scallop, because the pigments are within each individual cell, and by being within individual cells within the RP and the tight zonule occlusions, they're going to be well-delineated. It's like one single row of bricks, if you will. And over here, you can have formations of what we call lacunae, or little lakes, which is scabbing off of the pigment. There's another thing that we may see, you don't see it on this one, but I think I have it, and you maybe see it here on the border. But a lot of times they have a depigmented halo. Why? Because it literally steals the pigment from the adjacent RPE cell. This is not more cells, but just more pigment within the cell. The other side does not have well-delineated borders because it's in the choroid. It's not in the RPE, so there's no tight junction. There is an elevation, and it may have variation of pigment. Orange pigment on top is never a good thing. It's always suspected to be lipofuscin. And that's phagocytotic activity. Something is growing, something is moving faster than the photoreceptors can actually be recycled. Here's the example of the CHRPE with the actual halo surrounding it. So it's a depigmented area surrounding the area in question. So it's stealing the pigment from the side. And another great clinical pro, you're right behind the slit lamp, or you got your BIO, flip it to the red free. If it is a CHRPE, you put in a red free and it will enhance all the light being free from red, therefore green, will get absorbed at the RPE. If you're looking at a nevus and you put the same light, completely disappears because the light's being absorbed at the level of the RPE, does not enter in the choroid. It's a great way to be able to tell, are we dealing with a CHRPE, which is benign and I can follow once a year, or a nevus, and then I kind of have to question if I'm free from any transformation criteria. So we talked about fluid, lipofuscin, thickness, follow 6 months, follow a year, depending on what your follow-up guidelines are. Now, when we look at CHRPEs, we've heard of multiple CHRPEs. And oftentimes, and I've gotten several of these referrals in the past, we get worried about these, which are called bear tracks. But I want you to understand, bear tracks are completely benign. They're not Gardner syndrome. And we're going to talk about the difference here. If you look at the National Institute of Health, the bear tracks are literally paws of a bear circling, clustering on one single quadrant. These are very different than the CHRPEs that are associated with Gardner syndrome. Gardner syndrome is extra polyps that have a high propensity towards cancer inside the intestine. So these particular CHRPEs, and I'll show you 2 examples of 2 of our cases, are bilateral. They have a pisciform shape, almost like a torpedo shape to it. And they're not clustered in one single quadrant. They expand beyond a quadrant. These same criteria are the ones from the National Institute of Health, which I just gave you the guidelines right here on the bottom. So here's my example. These are what we call the pisciform shape. There's only a few. There's not going to be hundreds of them in one quadrant. There's bilateral presentation on them, and they expand beyond the quadrant. Here's another example of one. Here you can tell the pisciform-like shape, several of them. These are the ones you have to get a colonoscopy through a GI specialist. And the good news is that we have now genomics to be able to determine if the patient has a high propensity towards developing Gardner syndrome. Again, Gardner syndrome is the associated FAPS, which is multiple polyps within the GI, with we're almost talking about almost 100% propensity towards cancer. Given the fact this is a syndrome, we're looking at what's in the GI and then somewhere else, extra outside of the colon. And in this case, it could be CHRPEs, it could be cyst, it could be abnormal findings underneath the skin. Either one of you guys have seen any one of these cases before, a Gardner syndrome, or proven otherwise?
In my lifetime, I've had 1 patient. And then my question is, are these unilateral, are these findings here? These are great pictures to point out bear tracks versus these kind of football shaped lesions or rugby ball lesions. Are they unilateral or bilateral or both, Diana, when it comes to this condition?
I think it's more likely to be bilateral, but I've seen them in a unilateral presentation. I think
Yeah,
that if you see 1 or 2 and you see bilateral, or you see several and in uni, it doesn't matter. But it is more likely to be bilateral, but I've seen them uni.
Yeah. Usually what I've seen in presentations and talking to the retina guys is that bilateral but asymmetric, which kind of makes sense. That's usually how disease is. But these are beautiful pictures of those kind of football or rugby shaped lesions.
I thought this one right here, oh, I'm going straight into my little fuzzy wuzzies. Okay, this one I loved because it really had a great individual case, and also running in the family. So another thing that puts you from an educational perspective, if you already have a fear of it, get the whole entire family evaluated as well.
Fantastic. That's great. Another great clinical pearl.
So let's talk about our white fluffy lesions here. So, and what I tried to do in this particular case at hand is I was trying to put pictures that look somewhat similar, because oftentimes we're faced with, if I show you one single white area, it's hard for you to determine what is it. But if you kind of have them side by side, maybe we can pick up some of the subtle variations and be able to pick up different diagnostic findings. This particular case has 2 white lesions by the nerve. One is your typical count wool spot, the other one is not, and it's a differential for it. So instead of giving you the typical presentation of a myelinated nerve fiber, I wanted to give you one that looks very much like a count wool spot. So if I have a count wool spot in front of me and I have no history of hypertension, diabetes, a common entity, I'm doing a workup. A count wool spot should never be in the eye without any systemic history. And I'll share my clinical pearl that I've worked with my retinal specialist and my ophthalmologist, and I'd love to hear yours, Greg, or Joe's, just to kind of have a little basic for the doctors out there. But in the myelination, what I'm looking at here, it's a little subtle, but look at the striations here. We know that all the nerves in our bodies have this nice little myelin, which protects us against shock. So like an MS patient, the reason why the high propensity towards optic neuritis exists is because it is the perfect place where demyelination is going to occur, because it's normal not to have myelination outside of the nerve. We have all those different gliocytes and things that kind of prevent the myelin from coming through. If anything skipped through, that's where we're going to get these myelination. That's why they usually come off the nerve. But in a Cohen-Walsh spot, you have an ischemic event. The way you kind of think about it, you're at the turnpike, you kind of stop everything from moving along in both sides, everything swells up, everything stops, piles itself up. This is what a Cohen-Walsh spot is. It's nothing more than ischemic or swelling from arterial occlusion. OCT depicts it beautifully. Myelinations will have a striation throughout, and just like I told you with a Cohen-Walsh spot, it will be an elevated area. So if you have an OCT, great way to tell the difference. And if not, easiest way, and I like to do things very simplistic, so it's kind of talking from my previous academic world to my more practical world, just wait and see what happens. Here's a patient who's got Cohen-Walsh spot in both eyes, a small flame shape, some attenuation, typical hypertensive patient, comes in. Within a month, Cohen-Walsh spots disappearing. And within 6 weeks, they should be completely gone, depending on the timeline of when they started. The myelination will still be there. So best way to tell the difference, wait a month and see if they're still there. Photo document. Now I'm going to talk about my clinical pearl in regards to how I would work up in this particular case, my Cohen-Walsh spots, or kind of a screening for Cohen-Walsh spots. Joe or Greg, you guys have any comments regarding that last case or anything you want to add with myelinations or Cohen-Walsh spots?
The only thing I would add, if you go back to the OCT, would be, and you pointed it out earlier, was in the myelination, you can see how the light kind of goes through it, but in the Cohen-Walsh spot, it's so dense that you're getting a hypo-reflective column below it, if you want to point that out.
Excellent. That's actually a great perspective there. Can never beat you with those OCTs. You are the king of the OCTs. I love it. I love learning from you. That's a great example on there. And looking at over here. All right. So, lady comes in, 54-year-old African-American female, no past medical history. We have these patients all the time. Last time they had an exam, Joe has said this, I think in one of his lectures a long time ago, and that their labs came back with an APGAR score. And that was the last time they got their medical exam. So it's been a little while since this patient has gotten their medical exam. But nonetheless, Joe, if I'm going to give you jokes, I'm going to quote you because they were very good the first time, and I still remember them to this day. One thing I want to point out is a couple of things, which I think are very important in this retinal evaluation. There are numerous Cohen-Walsh spots and not much of the hemorrhagic representations, which I think is important to know. When we're looking at diabetes and hypertension, there's still a hemorrhagic disease, whether it be more superficial like flame shapes and hypertensive patients, or more dot blots because they're more internal in patients with diabetes. But here we have a lot of Cohen-Walsh spot. I need you to understand, you see all these changes out here, these are not hemorrhages, but there's actually a vasculopathy. And this same vasculopathy, how the retina is responding, is going to be seen in the optic nerve. So in looking at further, if you started with labs, you can be incredibly extensive. So you've got to tailor labs, and you got to understand insurances are not going to pay for every test under the sun. So we got to do this based on clinical presentation. I'm dealing with a 54 years old African-American. So what kind of diseases can run in those particular patients, knowing in fact she hasn't gone to a medical doctor. So your typical complete medical metabolic panel, your diabetes, your hypertension needs to be worked up. And then I look further into the clinical picture. I'll tell you exactly what ended up happening with her, but this is a good start for me. If I don't know anything, I'm going to go for my basic screeners and then move on from there. Vascular diseases are the most common entities: blood pressure, fasting blood sugar, HIV, basic metabolic panel, because then I can look at their kidneys, I can look at their liver. If anyone sees Grey's Anatomy, they never stop, they're ordering an MRI and a basic metabolic panel. It's a standard whenever you go to the ER. Complete blood workup can give us a lot with differentials, especially with leukemias, anemias, hyperviscosity, even coagulative factors. You need a PT, PTT, and INR. But some of the red blood cells, as you will see in a case later, may be seen. ESR, ANA, both from a screening of inflammatory entity, C-reactive protein can be added, and ANA from an autoimmune disease, not just lupus. These become screeners Then I get more into specifics. Guys, what would you like to add here or take away? Just as a very small basic, like, let me get started and then move forward.
I think this is a very good let me get started type of profile. I myself, in this situation, will co-manage with the primary care physician, who may be an internist, it may be a nurse practitioner or physician assistant, but I find them all to be very, very responsive. And we'll have the conversation. And I will pick up the phone and discuss it with them, and together we'll come up with what is a most likely profile or things to look at, because they can think of things that I may not think of. And then I do the handoff that way, because they can't examine the eye. They don't know what this means or what's going on. So where I am in my area, we have a very, very good collaborative working relationship with all kinds of medical professionals. And Diana, just so you know, that the phrase I tend to use now, and people who don't have health care, was her last physical was with a pediatrician.
I still like the FCAR score. I mean, that was one of my favorite. I still remember that.
Mhm.
But that's a
So
great.
Diana, I'm going to give 2 clinical pearls out. One, since maybe they'll come up here, cotton wool spots, is that we all have these wide field imaging, Optos is them, but I have an iDen, I have Optos, I have 2 cameras in my practice, so on and so forth. But the key is that do I work up every peripheral hemorrhage? Do I work up every dot hemorrhage? No, I observe them. Do I feel that one isolated cotton wool spot in one eye needs to be worked up? And the answer is yes. Now, in your case here that you're showing, I don't think it's high diabetes. I don't think it's high blood pressure, because you can check a blood pressure in the practice. But this is where I would say you need to reach out. Like Joe, I'm going to echo what Joe said. Reach out and talk to your primary care doc, the physician assistant, the internist, because they hear cotton wool spot. What's their initial finding going to be? Diabetes, high blood pressure. This is where we got to be interactive with and be part of the patient care and say, look, I don't think this is diabetes. I don't think this is hypertension. I took the blood pressure. Usually there's other dot and blot hemorrhages, exudation going on by the time you see cotton wool spots, and participate and kind of steer them down, now looking for the unicorns rather than the diabetes and the hypertension.
Excellent. And that's 100% correct. And this is indirectly what we did in this particular case. So the first one could be done as a screener. Here's one single cotton wool. Great point, Greg. One cotton wool spot should always be worked up. Looking at the overall clinical picture, which I'm going to tell you more on this particular case, and getting in touch with the primary or a primary. Remember, in her case, she doesn't have one. So we may be calling a friendly person to kind of educate them and bridge the gap here in between. But those are excellent point. And why be the hero in this case? This is their disease, and we're here to kind of give them more information of our findings and be able to take care of what we can. So in this particular case, she had leg swelling, periorbital swelling. This is all going to go together. And remember that even though this may not be hypertension directly, there could also be hypertensive changes associated with something else that's causing the cotton wool spot as well. So there's still importance of working things up, kidney dysfunction and diabetes, endocrinology, all working together, joint pain and fatigue. So there's other things going on. Also noting there is this peripapillary edema. So there's a little bit of swelling. Like I told you, the whole retina had a little bit of a swelling feel, but around the nerve, there was a little bit more swelling. And of course, African-American with this butterfly rash, the first thing that you start thinking of, which was a correct answer, was lupus, and it was undiagnosed. And all the other findings related to it were considered, because lupus affects anywhere. It's a multi-systemic disease, and it's going to affect the kidney, the heart, the skin, the joints, and 50% would have ocular findings. So you might be the one diagnosing the patient for the first time.
Hey, Diana, here's a question that came in. It's going to be a bit of a challenge. What about a child with a single cotton wool spot? No systemic symptoms or history that we're aware of.
I'd still, again, just like you said, Joe, working with a pediatrician is important, because there's a lot of other histories that we don't know or in tune that they're going to be working on. I still will do a pretty similar workup. And the one thing I want to allude you to be careful, we think of a child, and a child may be someone who we consider 10 years old, 11 years old. But HIV actually becomes very important in the younger population because I hate to say it, but kids have sex at a much younger age as well. So it's a hard conversation to have with parents too, and to start considering it. But I would do probably a similar one, and there's probably a lot of other stuff that the pediatrician may be thinking. And I get worried. I had just one recently who ended up, and it wasn't a Colville spot, it was raw spots, had leukemia in there, and it was a young patient. So I think going back to talking to the doctor becomes far more important. Any other questions? Most
None.
common, so kick it away, Greg, for this particular question. Polling question.
Yep. It's open. It's been running for a little bit. The most common cause of subretinal macular hemorrhage is choroidal neovascular membrane, idiopathic, vitreomacular traction, PVD, tractional PDR, proliferative diabetic retinopathy. Yeah, I think just to dovetail off of that question is that, geez, when we're thinking about adults and cotton wool spots, older, it's probably more kind of some type of ischemic-ish type of disease. And then you're getting into your anemias, leukemias, and blood dyscrasia, B12 and all that stuff. But boy, a child getting a cotton wool spot, someone that's super perfused, and now they're ischemic. Man, that kind of scares me, what's happening with that person.
And yeah, and hyperviscosity and coagulatives are high up there, but then you got all kinds of different autoimmune type of entities at hand. So that little one can make a big difference. There might be a heck of a workup. So I think, and it might even deal with rheumatologists, infectious disease, and a whole entire team. Did we get
All right, so here's your polling question. People are doing well with it. I had it opened up. I'm going to display the result here. And we have 57% going with choroidal neovascular membrane. We have 7% going idiopathic, and 17 equally with PVD, vitreomacular traction, and tractional proliferative diabetic retinopathy.
So to justify, and as we're going to talk about it, and I didn't give you enough information regarding the potential. We did say subretinal. So within the subretinal space, we're looking at the choroidal neovascular membrane being underneath and the outer retina, not having any vasculature and kind of feeding throughout. Idiopathic can certainly always be a cause of just about anything itself. But the vitreomacular traction and attractional PDRs, although they can lead to hemorrhages, these are usually superficial hemorrhages because of the fact that we're dealing with outside forces that are pulling the superficial vessels as opposed to coming from underneath. Choroidal neovascular membranes are common, obviously more common than, and we see them quite a bit. Number one cause in the elderly is probably wet AMD, but here I have a list of different causes. Among the top ones, choroidal rupture, trauma, histo, pending if you're in an endemic area, may even be more common than AMD. And myopic, please don't forget the myopes. We have always a tendency of getting these high myopes, rule out retinal break, retinal tear. Kind of forget to look at the macula. And the macula is very thin. It's almost ischemic in these patients. So that thinning aspect of ischemia can lead to choroidal neovascular membranes. As a matter of fact, it becomes even harder to see these patients because of the fact that they have large staphylomas, a lot of changes going on. So it may even be tougher to get some imaging on these patients. But if a myope comes to you and tells you that there is metamorphopsia or a change in their vision, please get an OCT. Very important, because we've seen quite a few myopes with very subtle choroidal neovascular membranes. They actually grow above the RPE and they don't become as hemorrhagic. These usually need injections Q1 month for about 3 months. And thankfully, they don't need continuous injections like AMD patients do. They kind of tend to grow and progress a bit differently. This is a case of any thought process, send it within a week. This is an urgency type of case.
Diana, leave that slide up there for 1 second. I just want to kind of point out the pathophysiology of this list here. If you think of angioid streaks and the definition, it's abnormal calcifications of Bruch's membrane, macular degeneration, drusen that form in Bruch's membrane, histoplasmosis, you get a disruption of Bruch's membrane, choroidal rupture, trauma, rupture of Bruch's membrane. So the pathophysiology here is when you have Bruch's membrane that's disrupted, kind of there's something mystical and magical about it, even though it's a few microns thin or thick, is that once you get Bruch's membrane disrupted. Once you get that crack in the sidewalk where seeds can kind of fall in and grow, now you've got the crack in Brooks membrane. Now you've got this potential for this healing to occur from the choroid to the retina with this choroidal neovascular membrane. And we all know that it's not a great vasculature that likes to bleed pretty easily, but these are all compromising Brooks membrane when you look at this list here. So
Excellent.
that's a great list.
By the way, Greg, love the metaphors. I use that metaphor and I quoted you on the sun, the clouds opening up and rays of sun for the hypertransmission for the GA. So excellent metaphors. I love them. So we're looking at two hemorrhages. Again, I'm trying to, from the basic perspective, trying to always put two differentials at hand so we can look carefully at what we're looking at. At first, they look similar. I used a black and white photo. I apologize because they're both actually my patients, and I just happened to have a black and white photo when I grabbed it really quick from my cases. And the other one, as you can tell, is a high myope. You can tell there's a staphyloma, and you can have the inundation, the peripapillary, the elongation of the eye, and you suspect them both to be the same. But in looking at the OCT, you're looking at one that's very superficial. I told you the choroidal neovascular membranes go, as Greg had mentioned, from Brooks membranes disruption onward. So we're looking at choroidal neovasculars come in during an ischemic event, VEGF pops up, and it grows inward into an outer retinal space. There's no vasculature there. So it's growing into a non-vasculature area. This one, superficial, didn't come from underneath and automatically grew all the way. This one came from the superficial vessels. This happened to be a patient of ours who was constipated. So I'm giving you the real story. For a couple of weeks, status post given birth, and within a short period of time, and the extra increased thoracic pressure led to a Valsalva maneuver, which led to the hemorrhage at hand. These patients become scared because that extra pressure, they feel they popped something in the eye, which technically they did, and they lose vision. That small hemorrhage leads to 2400 vision. But the beautiful thing about these, as long as you got a history, you follow these, they resolve on their own, there's no sequela. The other example may actually be a patient who doesn't have very severe decreased vision. This one does. But there's some who have very small neovascular membranes, even just parafoveal, and they just know there's a disruption. There's something going on, but their vision may not be affected tremendously. That's a neovascular membrane, and that one needs treatment right away. So in talking to the particular cases at hand, bringing up this particular case, and I apologize again, I grabbed my photos, and depending which clinic, I don't always have the best photos, so I'm giving you the best that I got, but I'm giving you real cases. 42-year-old African-American female comes in with acute vision loss. This retinopathy has been going around for quite some time. It didn't happen overnight. But the fact that they popped the vessel right next to the macula on the right eye caused to count fingers on the right eye. Other eye, perfect 20/20. That particular blood, I'm thankful because it brought the patient into the office. But I'm really concerned about this patient. You guys had mentioned about the one convulse spot in a young patient with ischemia. This is a perfect example. Look at the number of raw spots going on this patient. And the fact that their blood is so frail, it broke due to the fact that she was vomiting the night before because she's been fatigued, she's been sick, and it led to a Valsalva maneuver that led to the pre-retinal hemorrhage. So I'm incredibly concerned about this patient. So when we went back to academia, I love for people to bring this on the chat if they can to just answer me. When you're thinking about raw spot, and particularly during the time of academia, what was the first diagnosis you were told? Every raw spot equaled what? What was the thought process? What were you thinking? Because raw spots are usually more commonly associated with other entities than the ones that we learned in academia. So I'd love for anybody to chime in to the chat and just write a couple of answers, or maybe your own thought process of what kind of workup or what you're worried when you see raw spots.
So the first one to roll in is hypertension. So we're watching the chat here. So this is synchronous virtual. Great usage of it, Diana. Thanks for doing it. But we have one participant saying hypertension.
And the rest
Waiting,
of the time got
waiting
nervous.
for others to come in. What were we taught in school? There we go. We got cancer, leukemia, anemia.
Excellent, excellent. All great
So
choices.
anemia, leukemia. Then we have cancer, another anemia, endocarditis.
Bacterial endocarditis. That was the key one that I was waiting. That was the academic terminology. that we always thought about, but all the other ones that you guys are putting are actually far more important to me, particularly the leukemias, the anemias, and the cancers, and especially on this young lady, 42-year-old African-American female. Looking at her nerve, I think this is important to also note, and looking at the evaluation of the OCT, when we looked at her nerve, it didn't look bad. But if you do an OCT, this is a congested nerve. It's not edematous fully, and you can see the nerve fiber layer is not terribly swollen. There is a little bit of a difference between the eyes, 98 and 110. Anything over 10 micron differences or increase signifies change or signifies a difference between two eyes, by the way. It's just a technical term. But when looking at the picture here, you can see that it has a swollen, congested look. It doesn't have my butterfly-like appearance. It's not well delineated. And you're going to see what's going to happen after this patient actually gets treated. So we talked about the Valsalva, we talked about the hemorrhage, we talked about the reason why she came in. And we've spoken already about Valsalva. Whenever I see a superficial macular hemorrhage, and the best way to tell, because you don't have vessels right in the macula, so you can't quite tell is the vessel below it or above it, if it's right in the fovea area, is run an OCT. OCT will 100% tell you the structural and the anatomy of where it is. But if you got a history of been weightlifting, coughing, sneezing, vomiting, anything that increased pressure, and then it happened, it's almost acutely thereafter, then you usually can wait it out and it's going to resolve on its own, no sequela, no problems. If you don't have a history or you have findings like we were seeing in our particular case, especially with those number of raw spots, coagulative as well as hyperviscosity entities need to be further evaluated. And when it comes to raw spots, this is an example of another patient who was originally sent to us as believed to have an AION because of the amount of hemorrhages around the nerve. But if you look at it, this is the original picture that they were showing me. And this, by the way, this timeline was only a few weeks by the time they saw us. But look at all the blood that developed later. These hemorrhages were outside of the nerve, and the nerve is actually well delineated. So all this blood and this viscous-like appearance of the veins dilated and tortuous was basically a vein occlusion that was erupting even more, but it caused numerous blood areas, and some of these ended up being raw spots. And this patient, if I'm not mistaken, actually had leukemia. Our case here in this, hypertension, diabetes gets worked up, anemias and leukemias are on my top, but as a CYA, I will evaluate the patient for bacterial endocarditis. I don't believe it is. Most of those patients are probably sick. They have heart murmurs, fatigues, or something else. Has either one of you guys have seen raw spots associated with bacterial endocarditis as opposed to anything else? Joe or Greg?
I
I
have
don't know
not
that I
had a
have.
patient.
Yeah.
I
And
can't think of a case.
And I think between the three of us, we practiced for what, 75 years or so between the three of us? No, maybe.
Yeah,
20.
I'm on 29, so
Anyways, CBC with differentials, PT, PTT, that gives you your hyperviscosity and coagulative factor, a complete metabolic exam. All these were done on this particular patient. I'm going to show you the labs. Hemoglobin electrophoresis, and as a CYA, I did do the bacterial endocarditis kind of workup type of thing, doing an EKG, doing a heart, but I didn't really believe any of that was associated. Look at these labs. This is a really, this case and another case that I didn't show tonight about a sickle cell girl who was a young lady in her teens who was never diagnosed, came from the island, so she wasn't screened. It's one of my endearing cases, because I think as ODs, we really can make a big difference. And it's not always sending it to a retinal specialist or working with a retinal specialist. I worked with, like Joe did, with their primary care physician. Look at these labs. These are screaming severe iron deficiency anemia. And she had no idea. Her hemoglobin was extremely low. And the fact that it was so low by the time she went to the PCP, he was so nervous, sent her stat to a hematologist friend. They got her in within a day. They got a transfusion the next day. This is how nervous they were with the case. Now,
go back to that, Diana, because it wasn't highlighted, but it is boxed. Look at that hemoglobin at 3.4, and 11 is 11.1 here. If that was 9.9, the primary care docs, they would be screaming, what the heck's causing this? And this is 3.4. I mean, there is severe ischemia going on here.
when they started to do further evaluation, there was a lot more to this, but the eye was the one that revealed all this, and she had no idea. But they were so nervous, they literally got her a blood transfusion. They went to the hospital, she got a blood transfusion. And this is coming from a mom who has a daughter that technically had anemia misdiagnosed. And just like you said, she was like in the 10.3, and they never really looked into it as much, believe it or not, because it would go up to like 11.2 and then 10.3. Later on, I find out my daughter did have anemia. But nonetheless, a lot of the symptoms of anemia, the patients don't even realize about getting certain areas of our extremities cold, the headaches, the fatigue. Everyone blames it on stress. So you don't realize you actually don't have any perfusion. Here's the interesting perspective. This is pictures from within a month. Within a month, most of the hemorrhages, as you can tell here, resolved. The one in the center has been reabsorbing, hence the visual acuity. Count fingers to 20/30. Because that was just Valsalva. That was going to resolve, and I wasn't worried about that. Here's a hemorrhage, again, the example of it resolving. You can document it with the OCT. The nerve went from I just told you, that was a congestive nerve. The whole retina was ischemic in itself. The nerve was congested, really and truly revealed itself as a normal nerve below. And this was taken at 2 months, complete resolution. And we've been seeing her every 6 months, and she's been absolutely fine with the care of her primary care physician, hematologist, and now just taking iron pills. She actually doesn't have to have transfusion. The level, initially she was getting some, and then they leveled her out well with the iron pills. But this is a remarkable example that this woman could have been in a lot more danger if she waited a little bit longer of how low it was. Any other questions regarding that case?
Mm-mm.
No, you're good. I have no comments. I don't think there's anyone weighing in here.
So they all fell asleep right now? They all left?
Oh no, they're commenting. I got people texting me saying great lecture. Behind the scenes here. So it's great job.
My brother and my husband, they both text you, anonymously. Just kidding. Anyway, so we're looking at 2 cases here. Again, similarities at hand. I wanted to bring in more of these cases. These are 2 of my own. They look very similar. There is this superficial like hemorrhage right by the nerve coming off of a vasculature. But again, the small little details is the stuff that I don't want you to lose sight with. First one, 60-year-old male referred for possible wet AMD. Of course, he's an older male. I shouldn't say older, but he's in his 60s. He's got blood in the macula. My first diagnosis is always going to be considered to have wet AMD. But let's look at this carefully. This is not, what have we talked about wet AMD? Choroidal neovascular membrane growing through from the outer retina inward, right? So we're looking at sub-RPE, sub-retinal. This blood down here could have been AMD, but this one here is completely superficial, right along a vasculature here. Blood that actually feeds, or a disease that actually leads to blood in different layers is very particular to this disease, which can lead to vitreous hemorrhage, pre-retinal hemorrhage, subretinal, and sub-RP, all retinal layers. Also, looking at it carefully, here's your vein. This is an artery. This artery is feeding right into this white little bubble. And look at my OCT. This is not a dehemoglobalized hemorrhage. You wouldn't see that in the OCT. This is actually hypertransmission within the OCT associated with the finding at hand. FA could help you a little bit further. FA can reveal the subretinal blood, so it makes it easier for us to see it right here underneath the vessels. The pre-retinal blood, you can see it much better here over the vessels, and then the leakage coming from this weakened vasculature here. So let's see from a polling question. And again, just jump in on the chat. We don't have a polling question, I apologize. But on the chat, anyone have some differentials? There are definitely differentials here you can consider, but does anyone have a clinical diagnosis? Any thoughts regarding what this could be? Now, clinical pearls, take a look at the FA, that dilated area, the fact that you have blood in different layers, and the fact that the patient is a hypertensive patient. Does that give us a final clue?
And while they were doing that, Diane, I just kind of, I love giving out clinical pearls. It really doesn't have to do with this case. But I like to point out, like choroidal neovascular membranes, they usually bleed to 2 layers, right? So, in under the RPE, under the neurosensory retina, neovascularization from diabetes can bleed into the retina and above the retina. It's usually 2 different layers. This is kind of cool where these layers are bleeding, what the diagnosis of this is coming from. So, it's very, so this is kind of in that same area. You're pointing out arteries, you're pointing out the different layers of hemorrhaging. You showed the OCT, you got the FA here. So just kind of remember there's certain rules out there. Choroidal neovascular membrane will bleed into 2 layers, depending on where it is, subretinal or retinal. And this is the same thing here. So now they're starting to roll in. I just wanted to do that. We have macular aneurysm, ruptured macular aneurysm. We have a branch retinal vein occlusion, another branch retinal vein occlusion.
Excellent. And that's exactly it. The 2 major differentials at hand, that's why I showed you the 2 pictures before, was either the macroaneurysm or the BRVO. And this is definitely your RAM. So great example, but certainly a BRVO would have looked very similar. The difference, as Greg pointed out, and thank you for pointing that out, Greg, one is the different layers. A BRVO doesn't usually lead into a subretinal space, number one. And number 2 is the FA, although subtle, does point to the larger, although it's not terribly large, retinal arterial macroaneurysm, as opposed to a small micro, which are small dilations at the level of the capillary. Those would be the diabetic patients, as Greg pointed out. So these have different forms. I've seen all the variations. These are other cases. Some of them I've taken them from the internet. Some of them are mine. But the more fusiform-like tends to exudate more, and the more saccular, like someone talked about, the rupture bleeds because that weakened vasculature is going to break. The number 1 cause of this is hypertension. As far as treatment is concerned, there's variations. So when we see it and send it to a surgeon, as Jill pointed out, don't be surprised that you're like, I send it to you and you didn't treat it. Some of these, they may absorb because it would absorb. They will watch them because the actual blood reabsorbs, and that blood in itself produces a coagulative effect that will seal the actual aneurysm. So without doing laser or anything, it will close. If it's nowhere near the macula, small peripheral, they may actually watch it. Laser can be done, but they're often a little careful, especially if it's close to the macula. I've never seen a YAG done for this one. I have seen a YAG done for a hemorrhage that's a subhyaloid. And if there's a subhyaloid hemorrhage, particularly in the macula, and you want to dissipate it quicker, you literally put a YAG through the subhyaloid and let the blood, as you can tell in the examples here, feed outside of the vitreous outward. My surgeons hate doing that because oftentimes it leads to a very large vitreous hemorrhage. Although it reabsorbs, their visual acuity becomes even worse. Anti-VEGF is probably the treatment at hand. And you will see in the literature, although I don't ever see my surgeons do this, and I've worked with a number of, in my previous clinic, I worked with 5 retinal surgeons. In my current clinic, I work with 2, but we actually work with a lot of the surgeons in the community. It's what they call a pneumatic displacement. What it would be, nothing more than a gas bubble to push the blood outside of the area in question. During that time, anti-VEGF and even TPA has been used. Most retinal specialists do not have intravitreal TPA in the office. The ones that I had seen had been at Bascom as a clot buster, but since the other treatments work pretty effectively, they don't typically treat. Very important, manage the underlying disease. Hypertension is the original cause. Hypertension needs to be managed. Collaborative work with the primary care physician becomes very important. Now, for those of you guys who mentioned the BRVO, this is your BRVO case. Very similar, but all the blood, because the artery is crossing over a vein in and of itself, slowing down the blood within that one area, producing a blood clot, and then the blood just can't leave. It will explode, superficial blood. But I specifically put this one, which is a patient of mine's example. Why? Because this little tiny area that looks white, and it looks like, was this a raw spot? Is this a macroaneurysm? It's an area of dehemoglobalized blood. The blood will lose its oxygen over time, as we can see around here, and it becomes yellow. So in this particular case, and that's why I put them side by side, this was dehemoglobalized blood. Now, interesting enough for this particular case, the patient did have a little bit of macular edema, for sure. You see this parafoveal area? This will be an example of what that macular edema with the case that they had mentioned with the macular schisis would look like a macular schisis, because it looks like there is a separation, but this is actually fluid leading in. Yet there's some central fluid and a small PED. So if you kind of hide the blood and you hide the edema, you got a central serous and a PED. So the cause of the fluid in the central area was not associated with the BRVO. The patient had both a central serous as well as a BRVO. So in this particular case, we decided to watch rather than treat because the central fluid inside was a central serous that would resolve with time. So it's an interesting case nonetheless.
Diana, with your pointer, because you
Sure.
can see it, can you point out on that slide, the small retinal pigmented epithelium, not right there? Can you just point it out right there? And then just because a lot of the audience, you and I do this stuff and Joe do it all the time. So there's the PED. Now, where's the central serous fluid? Can you just point
Thank you
that
for
out?
bringing that up. Excellent example right here. Just like today, I should have brought a case that was sent as a PED, but it was a central serous. So this is fluid underneath the neurosensory, as Greg had pointed out about the different spaces, and this is fluid underneath the pigment epithelium. Oftentimes, maybe 60% of the cases, if you look through the different scans, you might find a very small PED in association with the neurosensory detachment, because the fluid's got to come from underneath. Another great, and I shouldn't have cut this off. Did I cut it off? Oh, no, here we go. Excellent example. Have you heard of the word pachychoroid before? Pachychoroid in new terminology. Joe, have you heard of it?
Of course, yes.
So pachychoroid's a new terminology you might see from your retinal specialist as far as a thickened choroid. This is an example of a pachychoroid. So we know that the fluid coming in was central serous, more likely. The choroid is quite thickened, and that's where the fluid is going to come in. And most of these patients have a thickened choroid, probably greater than 500 microns. Most patients with central serous will invariably have a very thickened choroid. Fluid leaks in through a PED. The PED will break one of those little zonules, and then the fluid leaks into the neurosensory retina. Neurosensory retina doesn't have tight junctions, so if it spreads, it gives you a smoke stag, which is not common, but it is classic on a fluorescein. Any other questions?
No, we're good.
Okay, so here was just an example of showing an AV nicking causing a stasis of the blood, and the blood in itself producing a blood clot, and that leads to a vein occlusion. Apologies because the image is a little blurry. I'll try to make it larger, but this patient had a very small flame-shaped hemorrhage here, and all this dilation led to some more peripheral hemorrhage. So it's a very small twig BRVO. This is a variation of many of my BRVOs before. This one here had been lasered in the past. But just to show you, it doesn't always look like the perfect classic picture that we learn in academia. There's a lot of variations. What you want to always look for is a dilated, distant, tortuous vein. You want to look for some blood. The may or may not be exudates, the may or may not be edema. And of course, always learn that there's extensive amount of changes, particularly lots of cow and wool spot. If there's an APD, decreased vision, that there's an ischemic event, and that could lead to neo in itself. Ready for our next question? We're almost done here. I can't hear. Greg, are you talking? Because I can't hear you.
Oh yeah, I was muted. Management of VMT with relatively good VA is typically observation, Jetria injections, pars plana vitrectomy, PVD or PPV, and laser photocoagulation. We got people responding. I have not displayed the answers yet, but I think we have a good trend going now. Observation, Jetria injections, pars plana vitrectomy, laser photocoagulation. Management of vitreomacular traction. Okay. For the sake of time, to give you a couple more minutes, I'll hit polling, and you got 92% saying observation, 2% going with Jetria, 4% pars plana vitrectomy, and 4% going with laser photocoagulation.
Excellent, excellent. Most of these are observed. So we're going to go relatively quickly here because I'm going to end with my last case and exactly on time. Tale of my two VMTs. Just had this case a couple of weeks back, actually a couple of weeks back as a return, but a month prior to. When I initially saw the patient, I actually thought we were dealing with an epiretinal membrane. Best corrected visual acuity was 20/40. Patient was complaining of distortion. Common cause is epiretinal membrane. And you can definitely see here some folds, but there was a pretty taut area of vitreomacular traction pulling forward, causing fluid and distending some traction to the RPE area. My question was, is there something else growing here? Many times I have more than one entity at hand, and you can see from my previous cases. So I had the patient come back, let me see, observe what's going on, and let's get an FA just in case. Patient comes back a month later. What happens? Complete resolution. This is not, I don't make this one up, true case. It was I was so impressed because it literally pulled off completely on its own, causing back to almost 20/20 visual acuity, complete restoration of the macula itself. In my next case, because I'm going to finish up pretty quick, patient starts with a VMA, becomes a VMT, mild change, and within a short period of time, full thickness hold. So these can go 50-50 depending on what you are dealing with. So you never know which ones can worsen. We had like another 100 slides to go over. We never even went through retinal holes or breaks or tears. That's a whole different lecture. But nonetheless, you never know. Most of these are observed and they can worsen. And if they do, the surgeons will do surgery, so no big deal. So I'm going to leave you with this final case for my intern. Intern comes in. He was so proud of himself, did his evaluation of the exam of the patient. And this is just to give you my last clinical pearl. 65-year-old with waviness, has a choroidal neovascular membrane. Intern made the right diagnosis, did fantastic. Completely forgot the patient probably has glaucoma too. Nerve fiber layer, small flame shape. Look at the notching coming along. Pressure wasn't very high. But the bottom line with these cases, and as I've shown you from previous cases, don't just look at what the patient's coming in. Take a look at every single detail at hand. Kind of digest the information of what the patient comes, clinical picture, the findings, because it becomes very important. So I'm leaving you with my last clinical pearl. Pay close attention, not just to the most obvious. Thank you, everyone. Appreciate your time.
Hey, Diane, before you go, there is a question that just rolled in. After an ERM peeled, will the distortion go away?
Great. Most of it is what we actually help to do. We do a vitrectomy and a peel. Usually we do it with ICG. So we expect most of the distortion to go away, but we don't guarantee any of it. Also, most of my surgeons will go in based on distortion, not visual acuity, because that's what we're aiming to get better. But it's really going to help how taut it is and how the retina resolves with time.
All right, Diane, you're getting your virtual round of applause. Everybody's very appreciative. We're certainly very appreciative. So if you stop sharing, Greg will take over.
Perfect. Oh, I gotta hold on because I'm on my desktop. And stop sharing. There you go, Greg. It's all yours.
Fantastic. I appreciate it. So before we conclude, if everyone looks at their screen right here, you'll see survey. I should put the little red dot, but there's a little red dot here. So you can start asking the survey. I really didn't have the slides to do this. So some of the survey questions might not be pertinent to the talk. Answer them how you want. We'll weed them out. I was just going from the outline when I was putting the survey questions together. With that being said, it looks like all the questions have been answered for this synchronous lecture. You're getting your virtual round of applause, as Joe has pointed out. More are rolling in. So Diana, thank you for a very passionate, clinically relevant, and that's what Joe and I like to give to the audience, clinically relevant lecture on learning the basics from retinal cases. Fantastic job.
Thank you again, guys. Really appreciate it. It was an honor and a pleasure. Have a great night, everybody.